Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Greetings. I'm Chris Bernheisel, professor of family and community medicine at the University of Cincinnati, family medicine physician, and podcast lead for Cardio's team best practices. In this podcast, we will discuss surgical weight loss therapies. This is part 2 of a 2-part series, with our previous discussion focused on obesity evaluation and medications for treatment. I'm thrilled to have with me today Dr. Ryan Farrell and Dr. Mike Holliday. Dr. Farrell is an associate professor in the Department of Pediatrics at Case Western Reserve University and a pediatric endocrinologist at Rainbow Babies and Children's Hospital in Cleveland. Dr. Holliday is an associate professor in the Department of Family and Community Medicine at the University of Cincinnati and a family physician. Both guests are members of Cardio's team best practices. In our previous podcast, we discussed obesity evaluation and medications for treatment. Today, I look forward to learning more about the surgical side of obesity treatment. Mike and Ryan, thanks for being here.
Thanks for having us, Chris. Looking forward to continuing our conversation on this very important topic.
Thanks, Chris. It's really a pleasure to be here.
Well, let's go ahead and get started. Mike, if you wouldn't mind, share with us a little bit of the significance of obesity in this country. How severe is it? How big is this epidemic?
Absolutely. Obesity is a profound problem in the U.S. with prevalence that's dramatically increased over the past 60 years. The prevalence of obesity in the U.S. population has increased steadily since the 60s, from 3.4% of adults in 1962 to almost 40% in 2016. As of 2020, the national obesity rate is closer to 43%. We see this problem in all age groups, with an obesity prevalence of just under 40% among adults 20 to 39, just under 45% among adults age 40 to 59, and 41.5% among adults 60 and older. It's also a problem in our pediatric population, with rates also on the rise. Among youth ages 2 to 19, the obesity prevalence is now closer to 20%. The total cost of chronic diseases due to American obesity and overweight is about $1.72 trillion, and this is equivalent to 9.3% of the U.S. gross domestic product. The estimated annual medical cost of obesity in the U.S. was nearly $173 billion in 2019. Obesity impacts health in many ways. It increases the risk of many other diseases and health problems. This includes heart disease, diabetes, hypertension, high cholesterol, liver disease, sleep apnea, and also many cancers. Obesity as a risk factor is by far the greatest contributor to the burden of chronic disease in the U.S., and this accounts for about 47% of the total cost of chronic diseases nationwide.
And Mike, that data is staggering. In our last podcast, we reviewed the medical treatment options for obesity, and today we're going to hit the surgical options. Mike, if you wouldn't mind, share with us, what is weight loss surgery?
Absolutely. Weight loss surgery helps patients living with obesity by reducing weight and improving metabolic diseases such as type 2 diabetes. Common weight loss procedures include restrictive procedures such as the sleeve gastrectomy, and also malabsorptive procedures such as the Roux-en-Y gastric bypass, and also duodenal switch procedures such as the single anastomosis duodenal ileal bypass with sleeve.
Yeah, how often are we seeing these surgeries utilized to treat obesity?
You know, these procedures are really underutilized, and in fact, only 1% of eligible patients end up getting metabolic surgery.
Yeah, why is that?
As you can imagine, there are system factors such as out-of-pocket costs, insurance coverage, and also access to bariatric surgical centers in places such as rural areas. But, you know, there are also patient and provider factors that we can address today, regardless of whatever system we're in.
Hey, Ryan, I'd love to pull you in on this one. What are some of the provider factors that discourage bariatric surgery?
So it appears based on one study, it's actually patients that are coming to their doctors to discuss weight loss surgery. Actually, about 70% of the time, it was the patient, not the provider, that brought this up. This might be due to the primary care provider's knowledge gaps about the therapy's indications or the benefits versus the risks. In another study, it was shown that less than half of primary care providers felt particularly comfortable providing long-term care to these patients after their surgery as well.
So there's this obstacle related to providers, but what about the patients? Is there any hesitancy on their side?
Yeah, patients, like many of their healthcare providers, have knowledge gaps about surgery indications, benefits, and risks. Also, some patients enrolled in a bariatric surgery program may drop out due to things like comorbidities that might pop up that slow the process down, things like increased cardiovascular risk that maybe prompts specialty pre-op evaluation requirements, or maybe there's substance use issues that require cessation and medically supervised weight loss documentation requirements. There's a lot of things that all have to kind of be done on the patient side ahead of moving forward with surgery. These are medically fragile kind of groups of patients with comorbidities that need to be considered ahead of major surgery, but that doesn't mean they wouldn't benefit from these types of procedures.
Hey, Mike, given these knowledge gaps that we're seeing both in patients and providers, what can primary care physicians do to help this out?
I think we can start by filling our own knowledge gaps about these procedures, and then we can share that knowledge with our patients. We all want our patients to make informed decisions about how to best manage their obesity. And to make that decision, patients need to know, what are the indications, the contraindications, the benefits, and the risks of the treatment options. And they also need to know that the post-operative follow-up is really important to maximize their success with weight loss and getting healthier, and also to minimize any complications.
Yeah, you mentioned that we need to know about the indications. What are those indications? Who should pursue or look into surgical intervention?
I think more people qualify for these procedures than many realize. This would include those with a BMI of 35 or greater, really regardless of comorbid disease presence or severity. Those with a BMI of 30 or greater who also have type 2 diabetes. And then those with a BMI of 30 or greater with serious comorbidities who have just not really achieved a durable weight loss or any metabolic benefits from other means, such as lifestyle and or medications. And these comorbidities, they include things such as obstructive sleep apnea, hypertension, and then also metabolic-associated steatotic liver disease.
That's a pretty large group of our patients who have unhealthy weight that could potentially qualify. But who shouldn't get these surgeries? What are the contraindications?
So contraindications include those with cardiopulmonary diseases such as unstable coronary artery disease, severe heart failure, and then those with end-stage lung disease. Those with active cancer should not get these procedures. Those who have advanced liver disease such as cirrhosis with portal hypertension. Those with uncontrolled drug and alcohol use disorders, Crohn's disease. Those with severely impaired intellectual capacity should not receive these procedures. And then those who are currently pregnant or plan to become pregnant in the next 1 to 2 years.
So, Ryan, it seems like there's a lot of patients that could potentially qualify for this surgical intervention. How effective are these interventions?
Yeah, so actually weight loss surgery probably has the best weight loss durability, which is anywhere between 50 and 60% excess weight loss at 10 years post-operatively. That's obviously enormous. This is also metabolic surgery, like we discussed earlier, often resulting in disease remission or improvement, including things like type 2 diabetes. We see remission upwards of 80% at 5 years. Hypertension resolution anywhere between 43 and 83% of the time. And then metabolic dysfunction-associated steatotic liver disease with things like resolution of fibrosis in a quarter of individuals, steatosis in about half of individuals, and inflammation in about half of individuals as well. Obstructive sleep apnea tends to improve, but although it may not entirely go away. So certainly we'll want to have things like repeat polysomnography post-operatively as well. And then hyperlipidemia, anywhere between 29 and 40% reduction in things like your triglycerides at 5 years post-operatively as well.
I mean, those are extraordinary results, Ryan. You look at that and you see actually curing of many diseases. That's incredible. How risky is this? I think a lot of people have anxieties about proceeding. How big of a risk is this?
These are major surgical procedures, but their risk is actually somewhat comparable to other fairly common procedures. As an example, the perioperative mortality rate of a sleeve gastrectomy is 0.05%, while the 30-day mortality after a laparoscopic cholecystectomy is 0.1 to 0.7%. One can use the American College of Surgeons National Surgical Quality Improvement Program risk calculator to compare surgical risk of specific weight loss surgical procedures to a procedure as common as a cholecystectomy.
And that's really helpful, especially comparing it to common surgeries we see. But of course, there are other complications. Mike, if you wouldn't mind going through some of those other complications that can be associated with bariatric surgery.
Early post-op complications occur in about 15% of patients, and these include bleeding, anastomotic leak or stricture, vomiting, infection, ileus, wound dehiscence, pulmonary embolism, and also electrolyte abnormalities. And reoperation is needed in about 3 to 7% of patients. Late complications include sleeve stricture, gastroesophageal reflux disease, and this is more so with sleeve gastrectomy. And this might influence someone's procedure selection as they're deciding to get metabolic surgery. Other complications include gallstones, incisional hernia, bone density loss in about 8 to 13% of patients, and also nutritional and vitamin deficiencies. There's also loose skin and even hypoglycemia, especially after malabsorptive procedures such as the Roux-en-Y gastric bypass.
Yeah, Mike, as a primary care physician, I hear these complications, and the early complications, of course, can be managed by the surgical team, but these later complications, that falls on us as primary care physicians. What advice would you give me and other providers who are managing patients for the long term?
I would focus on my role in team-based care of these patients. Early postoperative primary care includes partnering with the patient's bariatric surgeon to recognize any complications and also prevent dehydration from inadequate oral intake. Long-term primary care, the patient who's had metabolic surgery, includes preventing and addressing surgical and metabolic complications, adjusting treatment of pre-existing medical conditions, and also preventing micronutrient deficiencies. Because this management can be complex, I would use decision support tools such as checklists or order sets in the electronic health record to make things a bit more manageable.
Yeah, those checklists certainly can be valuable. I think it'd be worthwhile for us to take a little bit deeper dive in some of these long-term complications and how primary care physicians can address them. Mike, can you address that for me?
That's a great question. So the primary care provider can help prevent anastomotic ulceration, and this is a complication we certainly want to avoid. We can do this by encouraging smoking cessation and also considering the use of prophylactic proton pump inhibitors for about 90 days to 1 year, depending upon the risk. We can also avoid non-steroidal anti-inflammatory drugs and also oral bisphosphonates. Also, the primary care provider can recognize surgical complications such as anastomotic ulceration and others as potential causes for non-specific symptoms. So we see a lot of things in primary care such as nausea, vomiting, abdominal pain, and these might be early warning signs of surgical complications. And this could prompt further testing and also bariatric surgery consultation.
Yeah, thanks, Mike. Ryan, if you could also provide a little more information on the metabolic complications and what primary care physicians can do to help prevent.
So metabolic complications may include things like gallstones, decreased bone mineral density, kidney stones, and gout. So for cholelithiasis, patients who undergo bariatric surgery are at increased risk of developing gallstones as their weight drops precipitously. Ursodeoxycholic acid, 500 milligrams once daily for sleeve gastrectomy, or 300 milligrams twice a day for a Roux-en-Y gastric bypass or a biliopancreatic diversion with duodenal switch is recommended for 6 months postoperatively. To address bone density changes, so reduced bone density, as Mike mentioned, occurs in 8 to 13% of individuals, and it can be mitigated with adequate vitamin D and calcium supplementation. And obviously, you want to be checking dual energy X-ray absorptometry every 2 years. And again, as Mike mentioned just a moment ago, oral bisphosphonates really should not be used to treat osteoporosis in these patients. And then preventing kidney stones. Patients who have had specifically malabsorptive procedures are particularly at risk for that. Strategies to prevent stones may include just drinking enough water, at least 2 liters of water a day, maybe using calcium supplementation with calcium citrate, and avoiding excessive fat and oxalate intake as well. And then for preventing gout attacks, gout prophylaxis should be considered for any patient that has a history of gout prior to metabolic surgery.
What about medication adjustments? What should we be preparing to adjust after a patient with bariatric surgery? Mike?
Well, there are pharmacokinetic changes that can happen that require adjustment in dosage and dosage form. due to malabsorption and also changes in body weight. So, for example, if one thinks that a medicine is not being absorbed properly, there's some changes that can be made, such as switching from an extended release preparation, let's say of an antidepressant, to an immediate release one. This is why it's really important to reassess the medical management of all pre-existing conditions after surgery. The other problem is a good one to have, and that is many conditions improve after these surgical procedures. So medication deprescribing should be considered for metabolic conditions such as hypertension and diabetes as they improve from the procedure. So, for example, if a patient with type 2 diabetes was on less than 30 units of basal insulin prior to surgery, it really should be discontinued in order to avoid hypoglycemia. In a similar fashion, those who are being treated for hypertension might require decreases in the dosages of their medications. There's also evidence that continuing a glucagon-like peptide 1 or GLP-1 agonist can be beneficial to prevent weight regain later.
And Mike, what are some nutritional recommendations specifically related to vitamins or minerals?
Another important area to consider is nutritional management. This includes routine supplementation of micronutrients with 2 chewable adult multivitamins per day, along with additional calcium supplementation. The primary care provider caring for these patients needs to ensure that the multivitamins provide a minimum of micronutrient requirements, including iron of 45 to 60 milligrams of elemental iron for menstruating females, vitamin D of 3,000 units a day, and then more is needed to maintain 25-hydroxy-D levels above 30. Vitamin B12 of 350 micrograms a day, or enough to maintain normal B12 levels. And then postoperative calcium needs, they always require additional supplementation beyond the multivitamins. And this is going to vary by procedure. So the total needs that the patient has, and this includes from all sources, so food as well as supplements, varies by procedure. So for those who've had a biliopancreatic diversion with duodenal switch, they're going to need 1,800 to 2,400 milligrams per day. Those who've had a laparoscopic adjustable gastric banding, sleeve gastrectomy, or Roux-en-Y gastric bypass, they're going to need 1,200 to 1,500 milligrams per day. These total doses need to be divided so that each individual dose does not exceed 600 milligrams. And it's important to remember that calcium carbonate needs to be taken with food, whereas calcium citrate does not. Each dose of calcium needs to be separated by at least 4 hours, and calcium preparation should not be administered within 2 hours of multivitamin administration. In addition to these supplements, one has to monitor the micronutrients quarterly for the first year and then annually thereafter so that supplementation can be adjusted. The micronutrients depend on the procedure, but common deficiencies should be considered, and these include folate deficiency in up to 65%, vitamin D and calcium in up to 100% of patients, and then vitamin A deficiency in up to 70%. And as I mentioned before, because of the complexity of micronutrient management, I would recommend checklists and order sets in the electronic health record to make these visits a bit easier.
Yeah, as you were sharing this list, I kept on thinking, my goodness, order set is so critical, or a checklist is so critical for this. I'm sure there's a few more things that we need to be keeping in mind as primary care physician. Mike?
There's a couple things to consider. One is contraceptive counseling. So we want to delay pregnancy for 12 to 24 months after bariatric surgery. And there's 2 reasons for this. One, we want to maximize the metabolic benefits that occur from the surgery. So that's going to be putting the patient in a better situation for a better outcome. But we also want to reduce the nutritional risk of rapid weight loss in the early post-op period. We need to provide these patients with alternatives to oral hormonal contraceptives if they've had a malabsorptive procedure, such as a Roux-en-Y gastric bypass or a duodenal switch procedure. So the absorption of these hormonal contraceptives may not be adequate, and unattended pregnancy could result. So with respect to bone health, in addition to the nutritional recommendations of vitamin D and calcium supplementation, it's also recommended to obtain a DEXA scan 2 years post-surgery. If one does diagnose osteoporosis, it's important to remember not to use oral bisphosphonates because of the risk of anastomotic ulceration.
Earlier, Mike, you shared about the growing epidemic of obesity, not just in adults, but in adolescents. And we have a pediatric endocrinologist here, Ryan. I'd love to hear a little more information from you, Ryan, on adolescents and metabolic bariatric surgery. Is this something we can consider for children?
Yeah, so actually there's been an ongoing longitudinal study of adolescents that have undergone metabolic bariatric surgery, which is called the Teen Longitudinal Assessment of Bariatric Surgery, or Teen Labs study. This is an NIH-funded study. Enrolled a total of 161 adolescents that received gastric bypass surgery. And what was shown in that study was that weight loss, particularly in adolescents, was actually pretty similar compared to adults and appears to be maintained through at least 5 years, which is the most up-to-date and recent data that we have for adolescents from that study. 60% of the adolescents in the study maintained a reduction of at least 20% of their weight through 5 years, which is a bit lower than adolescents in the study. But, of note, the adolescents actually had a little bit higher BMI at baseline compared to adults. So there may be particular reasons why that might be the case.
Do we see the same thing related to comorbidities like hypertension and diabetes as we do for adults? How big of a benefit do we see for our children?
Yeah, so that's really what's important when we look at this in adolescents. The prevalence of type 2 diabetes dropped from 14% at baseline to just 2% at 5 years post-operation. In fact, adolescents were 27% more likely to have remission of diabetes compared to adults. And by year 5, no pediatric patients in the study were taking any diabetes medications. So this is so important, as we know that youth-onset type 2 diabetes is a profoundly more aggressive disease with really high rates of diabetes complications. Similarly, for hypertension, adolescents were 50% more likely to have remission of their blood pressure issues, and antihypertensive use for adolescents dropped from 57% at baseline to just 11% at 5 years.
That is incredible data. There's certainly a risk related to bariatric surgery, especially in adolescents, I'm sure. If you wouldn't mind, share with us some of those risks.
Yeah, so again, we have to speak to the potential risks of these types of surgeries in someone as young as these adolescents. So again, in this study, there were 3 deaths during the study. One patient actually had type 1 diabetes and then actually developed sepsis 3 years after surgery. And then the other 2 patients died of drug overdoses. So again, maybe just speaking to really kind of assessing the mental health aspects prior to proceeding with these types of big surgeries. But actually, the overall mortality rate between adults and adolescents in this study was pretty similar. A big issue to note was that a number of adolescents required subsequent abdominal surgeries. About 20% of kids needed a second surgery or more. The majority of those surgeries were actually cholecystectomies, so that's just something to particularly monitor in children over time. Micronutrient-wise, iron deficiency and vitamin D deficiency were a little bit more prevalent in adolescents than adults long-term, so that's something that we have to watch carefully, but certainly is treatable and addressable.
This is a permanent change, though. This is a surgical intervention that's permanent. I'm sure there's many people that worry about doing this procedure in such a young population. How do you respond to that, Ryan?
Yeah, so actually, the authors of the study for Teen Labs actually wanted to kind of speak to that as well. So actually they did a sub-analysis where they compared younger adolescents that were just 13 to 15 years old and compared them to the older adolescents that were 16 to 18 years of age. And so in that study, actually, the younger adolescents did just as well as the older adolescents, including for children that had surgery before even growth and puberty were complete. So in this study, younger children actually had similar outcomes for remission of hypertension and dyslipidemia. Weight loss and quality of life outcomes were also pretty similar. Younger kids still had great remission rates for type 2 diabetes, but it was actually slightly better in the older adolescents. And that might be in part because there were only 7 kids in the younger age group that actually had type 2. So just smaller numbers, I think, probably led to that difference there. Younger kids actually also had lower rates of micronutrient deficiencies. So all in all, actually, while we don't have data yet on these patients as they enter into adulthood, we do really see meaningful improvements across the age spectrum of adolescents.
So who would you consider a good candidate for this intervention?
Yeah, so criteria are available for metabolic bariatric surgery in adolescents. So it mirrors somewhat with adults. So adolescents that have either class 2 obesity, so that would mean a BMI of either 35 or 120% of the 95th percentile, with a comorbidity, so things like type 2 diabetes or metabolic dysfunction-associated steatotic liver disease, obstructive sleep apnea, hypertension, Or if a patient just has class 3 obesity without any comorbidity, they would also be a candidate. So class 3 obesity would be typically a BMI of 40 or 140 percentile or 140% of the 95th percentile. There should be obviously a thorough physical and a psychologic evaluation as part of determining an adolescent's eligibility for surgery. There really also needs to be really good family support to ensure adequate follow-up. These are assessments that really should be done at a center with expertise and ability to complete sort of that comprehensive assessment. Well, obviously, we're going to need some more long-term data. I think the 10-year data for this population should be reported pretty soon. But I think we as healthcare providers need to be more strongly considering metabolic surgery in adolescents, given the profundity of the data that we've seen to this point.
Yeah, I think I'm certainly struck by the strength of this information and data. I really wanted to thank both of you for coming in and sharing with us about surgical treatments for obesity. I really learned quite a bit. Some key points for me. One is that obesity within this country is an enormous problem and is growing, even in our adolescent population. Surgical intervention provides a method to not only lose weight, but actually also cure many of those metabolic diseases we encounter, such as type 2 diabetes. Unfortunately, we don't see it used all that much. It's greatly underutilized, with only 1% of eligible patients undergoing metabolic surgery. And we have opportunity as primary care physicians to close some knowledge gaps so that we can identify patients who would benefit from this intervention. It really seems like weight loss surgery has the best evidence for durability and leading to remission for a lot of these comorbidities. Also, I encourage listeners to check out our previous conversation on obesity evaluation and medications for treatment. Look for Cardio Podcast 43 at the Cardio website or wherever you get your podcasts. Mike and Ryan, thank you so much for being here.
Thank you. It was a pleasure.
Thank you. I really enjoyed the conversation today.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.